So I'm going to be talking about targeting CD37 in CLL. CD37 is a tetraspanin. Function in normal B cells is not entirely clear, and the known or the ligand, natural ligand, remains unknown. But we do know that the function in normal B cells shows moderate internalization and minimal shedding upon activation, co-associates with HLA-DR, CD81, CD82, and CD53. And we know that knockout mice show decreased IgG, but normal B cell development, however, they have decreased plasma cells, which may be the result of disruption of AKT signaling. We know that it's selectively expressed on mature B cells, CLL, and the majority of lymphoma cells, so thus this makes a rational therapeutic target. A number of agents that target CD37 have been evaluated or are in ongoing clinical trials, some of which are open in Europe. I want to highlight a couple. The IMGN529 is a study that's in a phase 1 trial. I know it's open at OSU, and there's some interesting preclinical data using a transgenic mouse model. I have a slide on that later. But the majority of this talk, I want to focus on TRU-016 or otlertuzumab, just to confuse us with obinutuzumab and all the mAbs. But so throughout, I'll refer to this as TRU-016. Phase 1 is completed. We'll talk about that. There's some other preliminary data that's available for a phase 1 in combination with bendamustine as well as rituximab. So what is this drug? Well, it's a SMIP, which is a small modular immune pharmaceutical derived from G28-1 antibody directed at CD37. Essentially what happens is you have an antibody here, and you remove this part, and you create a linker between the variable regions and a hinge on the constant FC portion, and you get the final molecule, which is has a smaller size compared to an antibody. So this slide doesn't do any justice for this really great paper down here from the Bird group talking about CD37 in some cell lines as well as in CLL cells. But essentially what we know is CD37 is tyrosine phosphorylated, and interestingly there's a real balance between pro-survival and pro-apoptotic signals. So for instance, you get actually activation or involvement of SHP1, which is a phosphatase, a non-receptor tyrosine phosphatase. Concurrently, you get SYK activation and recruitment of PI3K delta and gamma, and you get upregulation of BIM. And importantly, it's distinct from signaling pathways mediated by rituximab. Importantly, rituximab does not involve phosphatase activation of SHP, induces higher levels of ADCC than alemtuzumab and rituximab as well. So also from this same paper, if you look across, in vitro anyway, if you look across cytogenetic fish risk groups, you can see that it's active across all fish groups. So whether it's normal 17P, 13Q, 11Q, or 12Q has the same degree of cytotoxicity. So what are the clinical trials? I want to talk about the phase 1 trial, which has been published in Blood recently, and we'll talk a little bit about the phase 1b/2 with B, Trubion versus B alone, or bendamustine alone, and then the phase 1b in first-line CLL with Rituxan. So this is the single-agent trial, again, recently published in Blood. There's a phase 1 dose escalation in relapse CLL, and then a 1b in treatment-naive CLL, as well as relapse non-Hodgkin's lymphoma. So a pretty good representation as far as the patient population, median age of 66, about 40% were greater than the age of 70, and you can see about 30% here had deletion 17p. So no talk would be complete without the waterfall plot. This is a waterfall plot of the reduction in lymphocytes. So very effective at decreasing peripheral lymphocyte count. And as you go left to right, this is just different dosing strategies, and you can see that happens irrespective of the dose used. This is the lymph node response, which is not quite as impressive, but also does not seem to be as dose dependent. Again, these just represent different doses. This is the highest dose with the treatment-naive cohort. So what can we say about response in CLL? Well, We can say overall, the entire group of 96 patients, the overall response rate was 23%, or 20% by IWCLL, which remember incorporates CT scans. And all responses were PRs. I think the important thing to highlight is that 6 of 7 patients in the treatment-naive group responded to treatment. And conversely, basically nobody responded if you had 3 or more prior therapies. And that really remains unclear why. 16% of patients with 17p deletion responded. What about the NHL group? Excuse me. These data have not been published yet. What you can see is that there's minimal activity, 3 of 16 patients. 2 of the 8 patients with follicular had a response, none with mantle cell, and 1 minor response in a patient with Waldenstrom's. What I can say, having had a number of these patients on at our site on this study, a number of patients did have stable disease for a period of time. So we can't make much of this, obviously, in a phase 1 study, but here's the progression-free survival. The treatment-naive patients are here, and I can tell you, having seen some of these patients, this curve, if it were updated, is starting to fall off. And here's the relapse patient population. This is just to highlight that the response does not appear to matter, the PK does not appear to matter as far as the dosing or the effect, nor does the AUC. If you do look here, you can see this is the lowest dose. You do achieve therapeutic levels, and then if you get to the 10 milligram per kilogram, this is more sustained. This bottom line just represents the decrease in neoplastic B cells with treatment. So what about adverse events? It's really what you'd expect. About 20 to 30% of people had infusion reactions, very manageable, happened with the first couple doses. Only 2 resulted in discontinuation of drug out of the 96 patients. Both were infusion reactions. And as expected with other monoclonal antibodies or antibody-directed therapy, you can see neutropenia in a number of patients. But overall, very well tolerated. So those are the phase 1 results. What about in combination? Well, this is more of a registration path than anything, but it's combined with bendamustine. And in a phase 1 trial in 12 patients, and it was updated at ASH in 2012, and it showed activity, not surprisingly. So this led to the phase 2 trial of 65 patients. You had, they're randomized to receive this Trubion drug, or TRU-016, which is administered weekly times 8 weeks, and then every other week for 4 months, plus bendamustine at the relapse dose 70 per meter squared, versus bendamustine alone in a 1-to-1 randomization. And remember, this is assuming a 58% overall response rate with bendamustine alone based on the German CLL study group data with our benda. Age, again, is very reasonable for a CLL trial, 60 to 65. You can see it's a fit population and with a low Sears score. The O-bendamustine or the true bendamustine, they had more prior therapies, and then the bendamustine alone had more patients with p53 mutation. So what about response? What can we say about this? Well, we can say it's active, not surprisingly, with a 69% overall response rate, which compares favorably to bendamustine. Obviously, we'd like to see this versus our bendamustine. However, the CR rate is 14%. And again, cross-comparison you can't do, but it compares favorably with the German CLL study group data with a CR rate where there was a CR rate of 9% using bendamustine plus Rituxan. However, this slide is somewhat provocative, I think, in that if you have patients with 17p deletion or p53 mutation or both, they had activity with this combination. And the reason I say this is provocative, if you remember the German CLL study group, the response rate is 7%. So 1 of 14 patients responded in that group with 17p deletion, and it was a PR. So could there be a signal here? Perhaps, but I think that remains unknown since we don't have larger data sets. Again, overall survival looks good in this early phase study. The bottom line as far as toxicity, no increase in toxicity for what you would expect with bendamustine alone or our bendamustine. So I think as we move forward to more antibody approaches alone or non-genotoxic chemotherapy approaches, something like this is potentially promising. And this is a phase 1b trial that looked at TRU-016 plus rituximab in frontline CLL, patients not eligible for chemotherapy. And that include age, comorbidities, and primarily patient preference, which if you come visit me in Oregon, you'll see that the majority of patients don't want anything that has the word chemical in it. But it's open label and it's 24 patients. So the age is reasonable, but I think you'll see that despite the fact it's for patients that were ineligible for chemotherapy, you'll see that the majority, 58%, had a low SIRS score, or 40% were deemed fit. And then again, patient preference. And I think this highlights a number of things, really, where it highlights, sort of the Oregon standard. We actually didn't have the study open in Oregon, but it also highlights where we're going in the field. Overall response, so best at any time was 100%, and per investigator was 96%. Now, if you make it more stringent at the end of treatment using CT scans, you can see that response rate went down to 50%. However, it still compares very favorably to single agent R up front if you look at the Hainsworth data. And remember, at the time of this publication with a CR of 4 to 9%, we would have been using more of this criteria. Also, one patient was MRD negative by 5-color flow of bone marrow. I don't have further information on that patient. Serious adverse events, there really weren't any significant serious adverse events, no infusion reactions other than this SIRS response was noted, and this fever. So what can we tell from these clinical data? We know that this TRU-016 or otlatuzumab has modest single-agent activity, but clearly ineffective for multiply relapsed poor-risk disease, has significantly enhanced activity in combination, similar to anti-CD20 antibodies. The R combination, I think, is particularly promising given the low toxicity and efficacy. And there's so many unanswered questions, i.e., why do these patients with relapsed disease not really respond to treatment? We do see that with monoclonal antibody or CD20s as well. And what happens response with CD37 expression? I can tell you we went back and looked at this and it did not seem to correlate, but that's some ongoing work that needs to be looked at. And then what happens to CD37 expression over time? I think in vivo we need to understand that before we can identify this as a future therapeutic strategy. And what is the resistance mechanism in relapsed patients? That remains unclear. So this is my opinion on what are the next steps should we continue to pursue these agents. And also I felt left out without a slide showing this pathway of some sort, but as I mentioned, if you look at the mechanism of action of this drug, remember upon activation you get activation of SYK, recruitment of PI3 kinase delta and gamma, and thus AKT activation. And so there may be opportunities for some combination therapy. This is from that same initial paper from the OSU group, and John alluded to this yesterday, but you can see that with trastuzumab, which obviously does not target CD37 as a control, treated with DMSO or Cal-101, you can see some degree of cytotoxicity. Not surprisingly, Cal-101 not very cytotoxic by itself. However, if you treat with Cal-101 or idelalisib in combination with this drug, TRU-016, you can see improved cytotoxicity compared to the drug alone, the TRU-016 alone. So that may be a promising strategy. Well, what about other things? Should we give up on NHL? I told you there was modest activity. This is a germinal center follicular lymphoma cell line. You can see that this is the combination index here, so anything less than 1 is considered synergistic. This is really just an in vitro SYK inhibitor, and you can see that at increasing concentrations of the SYK inhibitor, you can see synergy. And then this is another, again, lab-based PI3 kinase inhibitor, and you can see significant synergy, really at very low concentrations. So switching gears a little bit, again, that was really looking at True 016, this adapter SMIP molecule. But IMGN 529 is a drug that's immunoconjugate. It also uses is an agent that is a microtubule disruptor. And in this mouse model, again, this work from OSU, you can see that in a transgenic mouse model with CD37 CLL mice, you can see that when you treat with this immunoconjugate, that you get improved survival of these animals compared to vehicle control and trastuzumab. This is a paper that actually came out in 2010 and provided some of the rationale for looking at this drug in mantle cell lymphoma. But this is basically a genome-wide DNA methylation analysis looking at a number of genes, and one of the 4 genes that popped up that was hypomethylated was CD37. And in fact, if you treat with this Trubion drug, or this True 016, you can see in this mantle cell lymphoma cell line, you can see decreased viability. So here's an example of a hypomethylated overactive gene that may be a therapeutic target. So can we use hypomethylation studies to help identify targets? And I think this may be a possibility, understanding that 0 of the 4 relapsed mantle cell patients responded to treatment. However, with some of these novel agents earlier in the course of therapy, it may be worth pursuing. So again, this is just my opinion. So when should we use this drug? Is it worth exploring? I think the answer is yes, but in upfront therapy, elderly unfit, can we get a population unlike the R plus this drug that truly is unfit, and it's not necessarily just patient preference, although that's not unreasonable either. And I think combination therapy with GA101, clearly idelalisib based on the preclinical work. Ibrutinib, given the concerns about interference with ADCC, maybe not in conjunction, but in some fashion, and then in combination with SYK inhibitors. What about rituximab failures or CD20 negative cases? I know obviously that happens over time with treatment, or cases that express very low levels of CD20. What about maintenance? We haven't talked much about maintenance using monoclonal antibodies or any antibody therapy. Could we look at that? And then in NHL, I definitely think this shouldn't die, but should be combined with these agents here, TKIs. Maybe chemoimmunotherapy. I think it seems to be hard. It's going to be hard to improve upon the chemoimmunotherapy we have, and thus adding another agent with cost and toxicity is probably not worth pursuing. And although the company has done this with in combination with bendamustine as sort of a registration pathway, my opinion is we should not pursue it in relapse disease as a single agent or standard single agent cytotoxic agents, because clearly I think that's not where we're moving in the field. And if you ever want to come give a talk in Oregon, happy to host you. Take you up skiing on Mount Hood, and that's just a nice view in the morning looking out across the valley as it's pouring rain under there, and we're up here. So thank you.